All right. So we've talked a little bit already about this learning outcome here, talking about the intercostal spaces, the pleural spaces, and the anatomical compartments. Notably, we've spoken about the intercostal spaces. I just want to go back for a moment and add a couple of images into this discussion of the intercostal spaces. So in case you're having trouble envisioning where these nerves and vessels that travel in the intercostal spaces are coming from, these are intercostal arteries that break off segmentally from, in this case, the thoracic aorta, and intercostal veins that drain segmentally, ultimately into the vena cava. And they are traveling with nerves that are called intercostal nerves that arise from the anterior ramus of spinal cord segments T1 to T11. And so if you recall, I'll come back to this image in a moment. If you recall, this is a cross-sectional view of a segmental spinal nerve, and we have that relatively small dorsal or posterior ramus that branches to supply the intrinsic back muscles. And then we have the relatively large ventral or anterior ramus that branches to supply most of the musculature of the body, as well as most of the skin. And in this case, it's the intercostal nerve arising from that anterior ramus and entering the intercostal space to travel all the way around the circumference of the thoracic cage. Now, if we go back to this image, which I've shamelessly stolen from this YouTube video, so if you want to check out this video, I think it's quite useful if you're having trouble envisioning this. You can see that the intercostal nerve, artery, and vein are traveling along in the costal groove of the superior rib of the intercostal space. And you can see that also that there's branches or collateral branches that arise about, and so they're giving rise to additional branches sort of on the flank of their path, the flank of the body. And so the primary intercostal nerve, artery, and vein are traveling in the costal groove of the superior rib in the intercostal space. And there are collaterals traveling adjacent to the inferior rib of the intercostal space. But when we talk about the main intercostal nerve, artery, and vein, we're talking about this group here. Good. All right. So the super main divisions of the thoracic cavity are threefold. You can see them here. So of course we have the right pulmonary cavity, the left pulmonary cavity, and between them is the mediastinum. And so they're shown here, very simple schematically, and here is CT, a transverse CT. And you can see the right and the left pulmonary cavities are dark on CT because they contain the lungs, which are full of air. And in between those 2 points is the mediastinum, which contains the heart and the great vessels, as well as some other components that are traveling centrally, like the esophagus and the trachea. And this is a good key to sort of a typical transverse CT scan in the level of the mediastinum. Now the pulmonary cavities, maybe I need coffee. There we go. The pulmonary cavities contain the lungs and the pleura. And there's lots of sort of named portions of pleura. I'll come back to this in a moment. This is this slide. Recall that the pleura are double-walled sacs that invest organs. So in this case, we're talking about the pulmonary pleura that invest the lungs. And the analogy here is an organ is a fist and it's growing into, in this case, a balloon, which is the double-walled sac of the pleura. So the lung is the fist and the balloon is the pleura. Now, the two main divisions of the pleura that are really important are the visceral pleura and the parietal pleura. And so the visceral pleura, shown here in orange, not purple, orange, opposes the lung directly, while the parietal pleura opposes the thoracic wall. And this on the right side is a normally inflated lung. So you can see that there's a pleural space filled with pleural fluid. And in normal health, the lung contains most of this pleural space, and it's coated in the visceral surface of the double-walled sac, while the parietal surface opposes the thoracic cage. And all of these other colors describe divisions of the parietal pleura. So for example, you have a cervical pleura pointing cervically. You have a costal pleura facing the lungs, a diaphragmatic pleura opposing the diaphragm, and finally a mediastinal portion of the pleura opposing the mediastinum on the midline. So we'll go back to this image just for a moment. And now you can see what we're talking about. So here, the pleura has been peeled open over the left lung, revealing 2 lobes of the left lung and 3 lobes of the right lung. Obviously, the trachea, which bifurcates at the carina, and then bifurcates into 2 primary bronchi, and there's a bronchial tree filling each of these lungs, which we'll talk about a bit more in a moment. You can also see clearly the cardiac notch and other portions of the lung, notably the costodiaphragmatic recesses, which are space at the inferior portion of the lungs. Now, this is the normal scenario, so we have a normally inflated lung. On the right is a collapsed lung. And so what's happened in this scenario is that the lung has lost volume, collapsed, and most of the pulmonary cavity is now taken up by the pleura. And this can happen in a number of ways clinically. It's also called, if the pleural space is filled with air, this is probably the most common scenario, it's called a pneumothorax, literally air in the thorax. And there's different ways this can happen. So again, we have our normally inflated lung here on the left and our collapsed lung on the right. And one way that can happen is through a puncture of the chest wall. So if it's a bullet or another penetrative type wound, air will rush in. And immediately what will happen is this pleural cavity, as it fills with air, the pressure in the pleural cavity will increase and it will force the lung to collapse. So the pressure is too high in the pleural cavity to allow the lung to inflate. And so this is a direct result of that loss of continuity I talked about in the previous video between the visceral pleura and the parietal pleura. So the coupling between the lung and the chest wall is lost. And so in order to reinflate in this scenario, you have to actually restore negative pressure in the pleural cavity. So you have to insert a tube, typically, unless this body can do this spontaneously, and extract air or vacuum air out of the pleural space. You can also have, in addition to a pneumothorax, air in that space, you can have a hemothorax, which is shown, which is accumulation of blood, or a hydrothorax, which is accumulation of another fluid in the pleural cavity. And I just want to review this slide because it's somewhat important. So this is one approach to accessing the pleura, and you access it via the intrathecal space, which makes sense. So you're going to go in between 2 ribs, not through a rib, and you're going to go through this muscular wall to access the pleural cavity, and you're going to do it in the middle of the intrathecal space, because remember that you have intercostal nerves and the collateral branches of the intercostal nerves, as well as arteries and veins, at the top and the bottom of each space. So you want to go in the middle to miss both of those bundles of nerves and vessels. Now, here I say thoracentesis and chest tube are interchangeable. They almost are. Typically in clinical practice, they represent different terms. So in case I've caused confusion, here's a reference. You can check that page. But thoracentesis really means what's shown here. A needle entering the pleural space, in this case to remove excess fluid. And this can be used therapeutically to restore, to remove fluid, to improve ventilation. It can also be used diagnostically to test the fluid, for example, for presence of cancer cells. And so you can use a needle in thoracentesis to draw off fluid in the intrapleural space. And you access the intrapleural space via the interthecal space. The insertion of a chest tube is typically, as in a tube, it's bigger than a needle. A tube is typically to access the inside of the lung. And so in case that is confusing, again, I'd like you to revisit this video, and we'll use those. Not quite, thoracentesis and chest tube are not quite equivalent. They vary typically, by my understanding, in the size of the tube you're using and the depth of the insertion, with thoracentesis targeting the intrapleural space and the chest tube targeting the intralung space. In this case, remember, this is the 9th rib, the 10th rib. This is more caudal than most clinical chest tube or thoracentesis procedures, where you go in between, I think it's T4 and T5, or one of the mid ribs. And this is, however, we need to know, remember, this is called the 9th intercostal space. There's also something sort of linking this to the pandemic. This is an example of an article that shows you what is required when you're going to do any previously simple procedure in a period of infectious disease. And so, as you might imagine, inserting anything, accessing the pleural or the lung cavity of a patient with COVID-19 becomes really complicated, because you're putting your staff at huge risk for infection. So this is just one of a host of studies that they've had to come up with to develop rapid best practices, for rapid development of best practices around these types of procedure. And it shows you everything from, how many people do you invite into the room? Do you let a trainee do this procedure? The answer is no. If someone has COVID, you go for an experienced staff person. And everything from negative pressure pumps away from the patient to putting bleach into the pump to kill any virus that might escape. So it's kind of an interesting side note to things that are common and easy to do in a trauma setting become really complicated in this circumstance. Now, when we're just sitting quietly learning anatomy, there is a space between the lungs that I've already alluded to. And so it's the costodiaphragmatic recess. So that's the space between the lungs and the parietal pleura. And so this is considerable when we're at rest, and this space contains, shown anterior, posterior, and lateral, pleural fluid, but not lung. And there are actually recesses sort of shown numerically in all of these positions. And of course, the costodiaphragmatic recess, when you're breathing vigorously, either due to using physical exertion or intentional effort of an inhale or an exhale, that costodiaphragmatic recess will be smaller. In addition, there's a few landmarks that I'd like you to sort of be familiar with. So where are the lungs relative to the ribs? Here are the numbered ribs. They give you sort of rib numbers for points of reference. For example, the 2nd rib lies near if you're at the level of the 2nd rib, you're right at the junction, the junction between the manubrium and the body of the sternum. And you're in the superior lobe of both lungs. Conversely, once you're caudal to the 6th rib, you're in the inferior lobe of both lungs. And that gives you some frames of reference to think about where you might be. You can also divide the lungs longitudinally using the peristernal, mid-clavicular, and mid-axillary line. And these are sort of important clinical landmarks that you want to be familiar with. And then the third way to orient yourself is, where am I relative to the vertebral body? And so, for example, you can see that this is the T12 spinous process. And at the level of the T12 spinous process, or the 12th rib, that marks, in most people, the end of the pleural space. Now, if you've been to any doctor for any physical exam ever, you've probably experienced thoracic percussion. And thoracic percussion, sort of classically, some people still do it this way, is sort of knocking on the back to produce resonance. Often now when we talk about thoracic percussion, we're talking about listening to sounds through a stethoscope. And so in a posterior view, this is the area of the zone of percussion, the percussion space where you can hear resonance in the pleural cavities. And as makes sense, it's between all of the bones except the ribs. So missing the scapula, scapulae and the vertebrae, and above or rostral to the level of the 12th thoracic vertebrae. And, you know, what are you listening for? So ideally, in a healthy person, you hear resonance. This should be a largely hollow cavity, so it should be full of air. So that's a good sign. The presence of fluid, as in COVID-19 pneumonia, will dull the resonance. And a solid, as in a solid tumor, would make a flat sound. I can't tell the difference myself, haven't been taught and tried, but that is kind of what clinicians are looking for in that area. You can also see immediately below this pulmonary zone of resonance, ooh, that was hard to say. So immediately caudal to the level of the T12 vertebrae are the kidneys. So you have your left and right kidney in this posterior view. And if you've ever been in for a quick check, you have a bladder infection, which is unfortunately very common. And they sort of knock on your kidneys. That's what they're checking for. So immediately caudal to the T12 vertebrae here on the posterior surface, you have a zone of visceral flatness, which is a full zone of your viscera, most superficially posteriorly, including the kidneys. And so if they knock on your back, they're checking, clinicians are checking to see if your bladder infection has traveled or spread to your kidneys, which is of course more serious. Now, all of us know, hopefully in this program, that the lungs bring inspired air into close relation with venous blood and pulmonary capillaries. And when you look at the lungs, you're looking at 2 lobes on the left, 3 lobes on the right, divided by a single oblique fissure in the left lung and a horizontal and an oblique fissure on the right lung. Because the bulk of the heart sits and deviates left of the midline, the cardiac notch takes out a portion and reduces the volume of the left lung compared to the right. And this little tongue-like progression is aptly named the lingula of the left lung. On the posterior surface, as you probably already know from lab, you have borders and surfaces of the lungs. So the inferior border is the edge of this surface that I'm looking at, and the flat surface that interfaces with the diaphragm is the diaphragmatic surface, or the base of the lung. Conversely, the apex of the lung is rostral. Okay, now here's a diagram that involves the diaphragm, that's hard to say, of the lungs in situ, or the lungs and heart as they are arranged in the body. And in this case, in the mediastinum, the pericardium has been peeled open, and you can see that the left lung has been just reflected a bit slightly, so you can see the root of the lung, or the hilum or hilum, depending on where you're from, which admits passage of the pulmonary arteries and veins, as well as the primary bronchus on this side, in this case, the left primary bronchus. Now, the point of this slide, though, is to emphasize that both hemi halves of the diaphragm here, and here are innervated by the phrenic nerve. And remember that the phrenic nerve descends bilaterally from C3, C4, and C5. So it's the motor axons from those segments of the spinal cord. And what this slide emphasizes is the relative position of the phrenic nerve, which lies immediately laterally to the vagus nerve on both sides of the body. So the phrenic nerve, we don't go into sort of the path of the detail of this a lot, but you should know that the phrenic nerve is descending from C3, 4, and 5 to innervate the diaphragm bilaterally. And the vagus nerve is descending from the brainstem to innervate the myocardium. And that also happens bilaterally. So it is possible to have a lesion of a single vagus nerve or a single phrenic nerve. Now, the tracheobronchial tree it's so named because it looks like an inverted tree. So in this analogy, the trachea is the trunk of the tree, and it subdivides and divides to create this complex tracheobronchial tree. So the trachea bifurcates at the carina, which is here, and gives rise to, at the carina, into two main bronchi. And that division of the trachea is at the sternal angle. So the sternal angle, I just pointed to the top of my manubrium. That's not where it is. It's between the manubrium and the body of the vertebrae. So that is where that division occurs in most people. And that's where the trachea bifurcates into the main left and right, main or primary bronchi, supplying each lung. In turn, each main bronchi divides into lobar bronchi, and each lobar bronchus divides into several tertiary or segmental bronchi. And so the colors on here represent the segmental bronchi because, and you know that because there's a lot of them. And of course, in the right lung, you would have a singular primary bronchus dividing into 3 lobar bronchi, which divide in turn into many tertiary bronchi. In the left lung, you'd have a primary left bronchus dividing into 2 lobar bronchi, in turn dividing into many tertiary bronchi. And again, this little dotted line on both sides is showing you the root or the hilum of the lung. Now, just sort of a quick review about sort of the airway. And the airway is divided into a conducting zone, which includes all of the anatomy we've just talked about, the trachea, the main bronchi, the lobar bronchi, the segmental bronchi, and even smaller divisions than that, subsegmental and bronchioles, and a respiratory zone where gas exchange takes place. And that is very small respiratory bronchioles that give way to alveoli. So it's divided into conducting and respiratory. And what happens in the conducting zone in terms of structure is that the structurally reinforced trachea with rings of cartilage gradually gives way to non-cartilaginous airways. So that's another division. As the airways become smaller in the conducting zone, they progressively lose cartilage. So you have this sort of very clearly cartilaginous tube of the trachea. Here's the point of the carina, C-A-R-I-N-A, at the level of the sternal angle between the manubrium and the body of the sternum. That in turn gives rise to the left and right primary or main bronchi, shown in purple. And then you have 3 lobar bronchi on the right, shown in yellow, 2 lobar bronchi on the left, shown in yellow, and then a bunch of progressively smaller respiratory pathways, conducting and respiratory pathways. Now, I'm not going to review blood flow through the heart and through the pulmonary circulation. I would hope that everybody knows this cold. If you don't know this cold, this is your moment to get it right. I just want to emphasize that just so you can see what's happening at the hilum of the lung. And so in addition to the primary bronchus, the hilum contains pulmonary arteries conducting blood away from the heart toward the pulmonary circulation, and the pulmonary veins, which are conducting blood back, oxygenated blood back to the heart for distribution. Okay. So this is the right lung, and that edit is what happens when you arrive at a slide and think, oh, is this the right lung? But yes, it's the right lung. So how you know it's the right lung here, what you want to recognize is that you're looking at a view of the mediastinal surface, or a view of the isolated right lung from the medial side. The reason we know that you're looking medially is because you can see the root or the hilum of the lung. And so this pleural sleeve is enclosing all of the structures as they enter and leave the lung, and that's the pulmonary arteries and veins, as well as the bronchi. Now, on the right lung, you can see a few tip-offs that you are on the right side. First, the groove for the superior vena cava is visible, which is deflected relatively right. The cardiac impression, which is shallow compared to the cardiac notch on the left lung, is here. And of course, the biggest tip-off is that there are 3 lobes and 2 fissures. So you have a horizontal fissure dividing superior from middle, and an oblique fissure dividing middle from inferior lobes. And this is only the case on the right lung. If you look up here, and I would not expect you to discern this from a section anatomically, but you should know it theoretically, that if you're told that there are superior, middle, and inferior lobar bronchi, immediately you know you're in the hilum of the right lung. The left lung in the same view looks quite different. So the biggest difference is the huge cardiac impression that's present on the left lung. And the space that is taken up is referred to as the cardiac notch. There's only one fissure. It is oblique, dividing 2 lobes, superior from inferior, of this lung. And there's a huge depression or groove created by the descending aorta and the aortic arch, which deflects relatively left in the chest. And so that's the tip-off. In addition, there's only a superior and inferior lobar bronchi because there are 2 lobes. Now, we talked about thoracocentesis, which is accessing the pleural space. There's also bronchoscopy, which is passing a tube into the airways, but not through the chest wall or the thoracic wall. This time you're starting rostrally through the nose and passing a tube into the trachea. And bronchoscopy is performed for a number of reasons. It can be performed diagnostically to see what's in the lungs, in terms of, for example, if you're looking at lung damage or looking for lung cancer. It can also be used therapeutically. This is a man driving his bronchoscope. The bronchoscope itself is a camera, but children tend to shove things intranasally, so up their nose. So it can also be used therapeutically, for example, to retrieve things like peanuts or Lego, or things that have been shoved up the nose and enter the airways. So here, this is what the fibrous rings of the whole trachea look like, looking down on the branch point into the lungs, which is the carina. Here's at the level of the cartilaginous carina, the branch point, and this is from the perspective of you're driving this from the head of the patient, so the left and the right bronchi are on either side. And here you've chosen to enter the right lung. So you've taken the sort of right main bronchus, and actually you're in an upper lobar bronchi, and you can see progressively smaller segmental bronchi as you progress more distally down the